We have the last keynote, and it's a true pleasure to welcome Professor Roberto Tuchman from the International University in Florida, Miami, and he has been in the field for a very long time. I asked him before if I can put it this way, but he has been in the field so long that already when he was very well known and had published, I don't know, hundreds of articles, I hardly knew what autism was, you know. So, and this should not indicate that he's maybe also a little bit older than I am. So it's really a pleasure to have you here, and I guess there's no one who knows that much about autism and the relation to epilepsy, and so I'm extremely excited to have you here. It's a pleasure, and welcome to Stockholm.
Thank you. Thank you very much, Sven, for that kind introduction, and Monica as well for helping with all of the coordination of everything. It's a wonderful conference, and I want to really thank all the other speakers because I've really learned so much and have been, I felt so engaged. I think the audience has been so engaged with all of the talks, and I think it's fantastic. And I think what I'm going to be doing is, again, touching, like everybody else I think here has, on a lot of common themes. And probably one of the first things that I'm going to be doing is really talking about in two different disorders that at face value are so different, right? When you think about autism spectrum disorders and you think about epilepsy. And I'm going to try to tie them in together. So I'm going to need you to kind of think differently as we go through this, because I think there's a lot of assumptions that we have made regarding this relationship that I'm hoping, especially for all of those young investigators here, this may bring new light into it. Now, I'm a clinician, and I have been, as Sven was saying, in this field for over 25 years. And specifically, I've always been interested in this relationship between autism spectrum disorders and epilepsy. And this is the hospital where I work at Miami Children's Hospital. And about 15 years ago, we built a developmental center as part of Miami Children's Hospital called the Dan Marino Miami Children's Hospital Dan Marino Center, which really serves children with autism and related disorders, as well as other neurodevelopmental disorders. So to start out with, I thought we'd get into a concept of how we think about things and how that affects, our perception, especially at face value, about how things are related. So if I was to ask you what image comes to mind when you think of Miami, you would probably think of this, right? And that's true. That's a little part of Miami, but is it really Miami? And then you'd say, well, what is, if we ask people in South Florida and Miami, what do they think the image of Sweden that they have? They would probably have this one. In fact, my wife asked me to thank all of you for bringing IKEA to South Florida, because it's been quite an important part of her life. But the reality is that if we really think about it, there are probably a lot more things in common between Miami and Sweden when we start getting really at what we could describe the molecular level in terms of relationships. And that's really how I want you to begin to think about this, not just that one thing causes the other, but how these things are interrelated and how that may help us understand both the pathophysiology, if you will, of autism spectrum disorders, but also the pathophysiology of epilepsy, and even, as we'll discuss, intellectual disability. So I will be discussing the epilepsies, and again, I will spend a little bit more time giving you definitions about epilepsy, because I am making the assumption that most of you are more expert in autism spectrum disorders than in the epilepsy. So I will spend some time in defining what we mean by that, because the concept of epilepsies are in certain ways very similar to the same struggles that we have in identifying autism spectrum disorders. And then what I'm going to do is I'm going to bring in intellectual disability, which again has been brought up in many different ways throughout the talks over the past couple of days. And I'm going to talk about the relationship both with epilepsy and with autism as a risk factor, and also just in terms of how the three of these disorders are interrelated. And as you can see by these arrows, there's a bidirectionality to it. And I think there is a bidirectionality in it in the sense that it might be more clear to see that epilepsy might have an impact on intellectual disability or on cognitive function. But I think it's also very clear that autism as well can impact cognitive function and how we measure it. And then I'm going to talk about these risk factors, such as intellectual disability, but more importantly, what's underlying that, such as the genetics, primarily, that are really the shared mechanisms between epilepsy, the autisms, and intellectual disability. This is an important, as a clinician, this is what we would say is the triad that we see very commonly in child neurology and neurodevelopmental disorders. And these things tend to travel together. And so I think now we have a little bit of an understanding why they do and the implications, that may have in terms of it being a process. How do you develop epilepsy, and how we get to what we call autism spectrum disorders is an important process that we need to understand. And in fact, I'm going to suggest throughout the talk that there are very specific processes that are in common, that are shared mechanisms between epilepsy, autism, and intellectual disability. And that this is very, very important to understand, because this is going to lead to more specific interventions, both at a behavioral level and the implications that has both for epilepsy and for autism, but also by understanding the molecular level, we will be able to have more specific targets that are going to be identified, which will allow us to develop more rational therapeutic types of interventions. So this is really my talk over the next hour. So the first thing that I want to point out is that there's been a shift in perspective, and I think we know how often we have rethought how we think about autism spectrum disorders. We now have a new classification system where we've made some changes into it. But at the end of the day, autism spectrum disorders is still defined purely by behavior. We don't have real good we don't have biological markers that allow us to define it. And people think that, in epilepsy, we do much better. That in fact, we can know for sure, what epilepsy syndrome a child has, and as such, we can have very, very targeted interventions for that. But in fact, we also struggle in the field of epilepsy in terms of classification systems, and there's been also a change in how we think about it as new biological understanding of different endophenotypes have really changed our view of how these syndromes work. And we're going to discuss this because I think it's important in understanding the relationship between these two disorders. And specifically, I think it's important to understand that both autism spectrum disorders and epilepsy have multiple etiologies. So they're both almost like symptoms of something else, right? So even in epilepsy, even though the definition of epilepsy is considered almost a disease, in fact, it is also secondary to so many different etiologies that are important to understand, many of which are genetic, just as they are in autism spectrum disorders. There's also a diverse clinical symptoms. So just like if somebody tells you that they saw a child with autism spectrum disorders, you wouldn't know what to expect. If somebody told me there's a child, that you're going to evaluate who has epilepsy, I would not know what to expect because the diversity of clinical symptoms is huge. Clearly as well influenced by level of cognitive function. And third, there are variable outcomes, right, in both of these disorders. So as we kind of look at epilepsy, we understand that this relationship in terms of what we need to understand is very similar in many ways to autism. There's a few things that make epilepsy a little bit easier in the sense that we define an epileptic seizure as a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity of the brain. So we have a very, very clear definition of it. But again, if you look at the definition, it's not solely an electrical definition. It's a clinical definition of behaviors. You can have an abnormal EEG or electroencephalogram and basically not have seizures. So an EEG could be very abnormal and still not necessarily mean that that person is having seizures, which is an important concept. A seizure really is an electrical event that is associated with abnormal electrical activity on the EEG. And epilepsy means really the occurrence of at least one epileptic seizure. This is, again, a definition that is changing a little bit, and basically, for operational purposes, most of the studies that have looked at the relationship of epilepsy and autism have used the operational definition of epilepsy, which is 2 seizures, at least 2 seizures, to say that you have epilepsy. It doesn't say anything else. That was just an operational definition that was used. But really, the definition of epilepsy, as is being done by the International League Against Epilepsy, is really a disorder of the brain characterized by enduring predisposition to generate epileptic seizures and by the neurobiological, cognitive, psychological, and social consequences of this condition. So the question is, what makes up epilepsy is not just the seizures, but really much more than that in terms of what is going on at the level of the brain. And then when we look at an EEG, what we're looking at is what we would call interictal epileptiform discharges, or another thing that you will read about is epileptiform activity, and both terms are used interchangeably. And they basically, they specifically are referring to spikes alone or accompanied by a slow wave, occurring either singly or in bursts and lasting at most 1 or 2 seconds. So there is a difference when you look at an EEG and when you read reports of a child had an abnormal EEG and you see 1 spike, and we have a lot of children who would say the EEG is abnormal. It is abnormal when you have these spikes. That is the definition. But that's very, very different than having all of these spikes together, which obviously this is going on for several seconds, would make it more likely to impair your ability to carry out an act. I think this is an important concept to think about when you read the literature on the relationship between autism and epilepsy and the EEG. In addition, I think it's the same way that we think about when does behavior become a disorder. So behavior becomes a disorder when it interferes with your life, right? And so that's how we define that. In the same way, an EEG, if it's abnormal, but it isn't having an impact, we have to take it very differently than if it is having an impact in terms of clinical symptoms that we can assess. And this is what can happen on an EEG. So you can have, again, remember an EEG is a point in time, and you can go from 1 spike into what would be described as electrical status epilepticus during slow wave sleep. And here, this is a very, very different type of clinical picture in which it really is hypothesized that behavioral and cognitive manifestations of these sleep-related encephalopathies, because these EEG changes are activated during sleep, this can account for a lot of the behavioral and cognitive abnormalities that we see in these type of encephalopathies. What is an epileptic encephalopathy? What is the definition of that? Really, it's a terminology that it's, again, in flux. But the thought is that it's a condition in which the epileptiform abnormalities, these are the EEG spike and wave abnormalities themselves, are believed to contribute to the progressive disturbance in cerebral function. So not necessarily just the seizures, but actually just the electrical activity itself, has a contribution. And so there are several examples of syndromes like this, one of which we will discuss, and I'm going to show you a little video on, which is infantile spasms, or West syndrome. Then there is Dravet syndrome, in which we now know the gene is a sodium channel gene, as CN1A, which is associated as well with a very abnormal EEG, seizures, and behavioral and cognitive manifestations very similar to what would be seen in autism spectrum disorder. And then there was one particular syndrome, the Landau-Kleffner syndrome, also known as epileptic aphasia, which is related with epilepsy with continuous spike and waves during slow wave sleep, which there has been a long history in terms of the relationship of autism spectrum disorders, especially in those kids who have regression. Because in Landau-Kleffner syndrome, what happens is these are children who were described by Dr. Landau and Dr. Kleffner in the 1950s when they went into a ward for deaf people and they did some EEGs and they noticed some abnormalities. And these had been children whom were really word deaf without being really truly deaf. And so it was really an auditory aphasia in terms of what was going on. And these were kids who had developed normally up till about the age of 3, and then they lose their language. And they do develop behaviors that are consistent with autism spectrum disorders. Do they meet full criteria or not? Again, as we've discussed, they are definitely consistent with it. And so the question was, are there a group of children with autism spectrum disorders in which regression, we know that there is a group that does have regression. About 30% of children, by some studies, may have a regression in their language. But when we look at it, what happens in autism spectrum disorders, the regression is usually much earlier. Usually happens around 18 to 24 months. It usually only involves, a few words or some of the precursors of language, such as pointing and social interaction. And so it's a very, very different syndrome than the epileptic aphasia. But it's been confused a lot and has led some people to use the treatments that we use for Landau-Kleffner syndrome. There was a time in the United States when these children with autism and regression and abnormal EEG were being treated with steroids, as has been used appropriately for Landau-Kleffner syndrome, and other medications such as valproic acid. And again, I think it's, again, a leap that has been taken that was incorrect, and again, a misrepresentation of what's really going on. So I think it's important from a historical perspective and even from an ongoing perspective to really think about this relationship as we understand the conditions such as these epileptic encephalopathies. So let me show you just what infantile spasms look like. That was the seizure. Do you see it? That's another one. And you can see the EEG changes. You have what's known as an electrodevelopmental response when you see it going. It's a little head nod. You see it again. Sometimes very, very subtle. So the seizure itself doesn't look, that impressive, and obviously can be easily missed. But this is an abnormality in terms of when we look at the EEG. This is what it looks like. It's rather chaotic, and there's very poor organization of the background in terms of the kinds of waves that we would want to see. And when we have a seizure, we have this big group of spikes followed by a total attenuation of the background, and that is what's known as an electrodevelopmental response. So it's interesting that this is really this abnormal electrical activity that can influence the outcome. Why am I talking so much about infantile spasms? Because in fact, they're rare epilepsy, but they account for a large number of the children with autism that we see with epilepsies. That is about, as we'll discuss later, about 30% of children with infantile spasms go on to develop autism spectrum disorders, despite treating them and despite their seizures going away. So that becomes an important model to understand what else is going on at that level. Now, as I was saying earlier, I became involved with this about 25 years ago. And I was really trained at that point. I was training in epilepsy and doing an electrophysiology fellowship at Albert Einstein. I was lucky enough that where I was doing my training in neurology, which was where I did also my EEG fellowship, Isabel Rappin had been there. And she had collected, for those of you who don't know, Isabel Rappin is a child neurologist whom really was a pioneer in terms of understanding autism spectrum disorders from a neurological perspective, because she was talking about it way before anybody else had been in neurology. And she had collected over a 30-year period about 314 children with autism spectrum disorders, probably more, but I had, we compared them to 237 children with specific language impairments. And this was a very important cohort because she had made descriptions of everything that the child had. So we were able to go back and use the DSM criteria applicable to the time to really classify the children. So what I did is I went back and took all of her notes, made a database, inputted all of these patients, and then we were able to look a lot of their characteristics. Just to give you an idea of when we started thinking, this was, 1980s, 1990, and I think in the previous talk by Marcia, she had mentioned the fact that around 1990 there was a whole boom in autism, and we started seeing a lot more autism. Well, after this study was done, I went down to Miami to start my own practice, if you will. And in just 2 years, I collected 585 children with autism spectrum disorders. So again, using the same criteria before. So understanding that, the recognition of autism increased significantly during that time. And in the studies that I did in Miami, what we were looking at was not only the role of epilepsy, but whether there was a relationship with the EEG and without epilepsy in terms of regression. And here's some of the data that we got. And this is a picture that kind of summarizes pretty much what we know now, and I'll bring it into the modern times, if you will, because this is already an old study. But really, what we found is that there was 2 peaks. And again, this is a little bit debated still. But prior to the age of 5, there was a group of kids who really had epileptic encephalopathy, or what we would call developmental epilepsies. And these were the children that we identified almost with epilepsy first. That's when they started, and then we were able to identify the autism. And if you look at it, here again, we can see the association with intellectual disability, in which the cumulative risk was 6% with autism and no intellectual disability, 27% in children with autism and severe intellectual disability. And if you had intellectual disability and cerebral palsy or significant motor deficit, the cumulative risk was 67% by age 10. We seem to be like a little bit of a flattening of the curve between age 5 and 10, and this had been previously reported as well in other studies. And then there was a secondary peak, and we didn't really, in this study we hadn't extended it that much, but later on this got extended, and I'm using the Bolton data, which I'll go over in a second, to really show that, again, if you go out into the third and later on decades, you can still see that there is a continuous increase in seizures. So we don't know a lot about what happens in adults, but it looks like the risk for developing seizures in autism spectrum disorders doesn't stop. It keeps on being a risk throughout the lifespan. This group here includes not only epileptic encephalopathies, but also what we would call developmental epilepsies. A lot of these are the kids that we see with genetic disorders, such as Angelman and whatnot. We excluded at that point known causes, but again, in this population and in populations where they're coming to a neurologist, you're much more likely to see seizures early in life, because that's what they come into a neurologist, and then you'll see the diagnosis of autism later on. While in the groups and cohorts that are really specifically autism cohorts, as we're going to see later on, you're more likely to see the seizures occurring after the age of 10. And so it may be that there's 2 different subsets of children that we're really looking at. So in the Bolton study, what they looked at, again, this was a genetic study, and it was a cohort from 1950 through 1985 with about 150 children, and it was done for genetic purposes. And there they found that epilepsy was present in 22% of individuals, with the mean age of seizure onset was 13.3 years, and the majority was post age 10 years. So again, that was the kind of cohort they were looking at, which was autism first. And epilepsy was, again, more common in those with intellectual disability, low levels of language, and in females. And this whole issue of females, we also found that to be true in our initial studies. But when we looked at it more closely, we felt that it was all due to the fact that females were much less likely to be diagnosed with autism, especially back in the 1980s, but were more likely, when they were diagnosed with autism, to have intellectual disability. And we thought that the intellectual disability was really what was accounting for that. And then the other interesting thing from the Bolton cohort was that the presence of epilepsy in the proband was a significant predictor of a relative having the broader autism phenotype. Again, the familial aspect, okay, was being brought out in this study very clearly. And then Amiet had done a meta-analysis of 24 reports on autism and epilepsy published from 1963 to 2006. And here's the pooled prevalence of epilepsy. Again, in individuals with IQ less than 70, the pooled prevalence is about 21%, while in individuals with IQ above 70, it was 8%. And these are the numbers that you're going to keep on seeing throughout the different cohorts that we're going to look at in terms of that. So it's important. So clearly, intellectual disability comes out in this study, as it did in another meta-analysis, more recent, by Wolfenson from 2012, in which she had a different set of studies. Only one study overlapped with the Amiet meta-analysis. And again, 4 studies showed no intellectual disability, and age at follow-up was greater than 12, so they were going out further out. And again, the rate of epilepsy in this group was 8.9%. And the ones with intellectual disability, the rate was 23.7%. Now, there were less studies in children less than 12 years because, again, a lot of those studies would have had to come out from neurology-type clinics and not from autism centers, if you will. The importance here is that it's clear that intellectual disability is a risk factor when we talk about autism and epilepsy. They're much more likely to have epilepsy if you have a child with autism and intellectual disability. But 8.9% in children with no intellectual disability, that is IQ greater than 70, is still approximately 8 times higher than we would expect in the general population. So the prevalence of epilepsy in the general population is about 1 to 2%. And so having 8.9% is still much higher. Here's another study that came out recently in 2013, which was a cross-sectional study using 4 samples of children with autism spectrum disorders. They had a total sample of 5,850 participants with autism spectrum disorders. And again, you can see that the group 13 and older were much more likely to have had seizures. This is the percent diagnosed with epilepsy. Important to point out, this was again, an autism cohort being looked at genetically, so you would see much less 6 and under, and then you see much higher above the age of 10. And what they did a multivariate regression model, and only age and cognitive ability were independently associated with epilepsy. The average prevalence of epilepsy was 12% and reached 26% by adolescents. So again, when you look at autism and epilepsy studies from an epidemiological perspective, besides looking at intellectual disability, you're going to have to actually also look and see what age the cohort was being followed to in terms that seizures will continue even into adulthood. Interestingly, children aged 10 or older had 2.35 times the odds of being diagnosed with epilepsy, And for one standard deviation increase in IQ, the odds of having epilepsy decreased by 47%. Again, showing this very tight relationship between autism, epilepsy, and intellectual disability. The same group did another study that got published in Autism, in the journal Autism, and looking at the association between epilepsy and autism symptoms and maladaptive behaviors in children with autism spectrum disorders. So trying to see if there was anything more specific that we can say about this. And they used, they had 2,600 children from the Simon Simplex collection, again, a genetic collection, 139 with epilepsy. And children with autism and epilepsy had significantly more autism symptoms and maladaptive behaviors than children without epilepsy. However, after adjusting for IQ, only hyperactive symptoms remained significantly increased, that were 13% higher in the epilepsy group. So it wasn't the autism, but really these very specific behaviors. And among children with ASD without co-occurring intellectual disability, children with epilepsy had significantly more irritability and hyperactivity symptoms, suggestive of attention deficit and hyperactivity disorder than much more than the association with autism. We did a study, actually, Mike Kukuro, who is a psychologist at University of Miami with the Human Genome Project, did a study using latent class cluster analysis to see, again, if we could tease out, other particular groupings of behaviors that might help us predict the risk of developing epilepsy. And there was a total of 5 different clusters. And I think it's interesting that cluster 1, which was the most developmentally impaired. This would be the kids who had a global developmental disorders. And global developmental disorder under the age of 5 would then translate into intellectual disability. And 11% of that group had epilepsy. If you looked at the groups of children who had the least cognitive impairment, when we had IQ measurements above 70, then the rate, again, very consistent with what all in the literature have previously said, about 8%. In those with language regression, again, not a very clear risk factor to have language regression, not really the same way that we would expect in an epileptic encephalopathy such as Landau-Kleffner syndrome. Epilepsy there was only about 11%. The group that was the highest had an earlier age of ASD recognition. And one of the interesting things that we noted was a greater rate of repetitive object use and unusual sensory interest. So this restricting repetitive behaviors and interests is one of the things that was very interesting that nobody had really looked at in terms of potentially being a predictor of autism spectrum disorders. Clearly, this group still had some other developmental problems with late onset of first words and a high frequency of gross motor coordination problems. The other thing that I think has been pointed out by several people that is worth mentioning is the fact that this is a really important subgroup of patients to really look at in terms of those with epilepsy and autism spectrum disorders, because really they do worse than any other subgroup. There have now been several studies, some from Sweden, Danielson's and Gilbert studies, showing that in fact the morbidity and mortality is much higher. So other than the Gilbert study, other than drowning, the leading cause of death in autism is epilepsy. And then if you look at it from the other way around, a Finnish study done by Dr. Salampa and Dr. Shinar, looking at long-term mortality in childhood epilepsy, the kids who had the sudden death, which is seen in epilepsy, were much more likely to have intellectual disability and autism behaviors, along with their intractable epilepsy. And when we did a study in the United States, Jane Pickett, part of the Autism Speaks Autism Tissue Project, when we looked at the records of mortality in the state of California, we found that 30% of the brains that are being studied from the Autism Tissue Program were of children with epilepsy. And it's probably higher than 30%. The records are really poorly kept in terms of what causes death. And so this is an important point because, again, epilepsy may also have contributed to what we're looking at in terms of the changes in the brain, or maybe, again, just understanding, this from a clinical perspective is important to note. So when we think about, how we are speaking to families, with children with autism and epilepsy, especially those who have severe epilepsies and autism, we really need to keep this in mind, that their risk is much higher, and we should counsel them. It's also important to realize that this is an important subset to identify early when we start thinking about treatment implications. Then the other question that we need to ask is, how often do autism spectrum disorders occur in epilepsy? So most of the studies that we've done, we started out with a cohort which was diagnosed with autism, and we'd said, okay, how many of these kids have epilepsy? But there's fewer studies that have really looked at an epilepsy population, diagnosed first with epilepsy, and said how many of these kids have autism spectrum disorder. So in this study done by a group from Chicago, in an epilepsy clinic, in a tertiary epilepsy clinic, they found that 37% of 65 children, average age 2.5, screened positive using MCHAT for autism spectrum disorders. In another study done by Clark in Tennessee found that 30% of children with epilepsy screened positive for ASD in the social communication questionnaire. And again, the ASD was highest in seizures who started around age 2 years or earlier. And again, this was a tertiary epilepsy clinic. So these were the kids who had more intractable types of seizure disorders. In the studies from Iceland by Samuelsson, what they did is they looked at a population with epilepsy in the first year of life. And what was found was that 7% of children with, they had, in this population, which seizures started in the first year of life, 7% had autism spectrum disorder, all with intellectual disability. 46% of those with infantile spasms ended up having autism spectrum disorders, and these were diagnosed using, ADAS and ADI tools. And 69% of those whose seizures was associated with brain insults. But these insults were not really huge. I mean, some of these things are not that bad, such as sepsis, that really may not have really affected the brain. So you think about also what are the genetic underpinnings, behind this group here, and what can we learn from that. In a nationally representative population out of UK, which 7,000 patients, the ASD in population of individuals with epilepsy 16 years and older was 8.1%. Again, same numbers over and over. And after adjusting for verbal IQ, an individual with epilepsy had a 7-fold increase of having an autism spectrum disorder. So again, when you look at an epilepsy population, they're much more higher risk for developing autism. And then this was a community cohort that had been studied in the community for many years, following children with seizures and having their first seizure, and then what happened to them in terms of what was going on. And then we retrospectively went back and looked at those kids and said how many of those kids met criteria for autism spectrum disorder. And 5% met criteria for autism spectrum disorder. 10% of those whose seizures started in the first 2 years met criteria for autism spectrum disorders. And 13.8% in those with IQ less than 80 met criteria for autism spectrum disorders. And 2.2% with normal cognitive abilities met criteria for autism. And again, when we looked at specifically at the children with infantile spasms, 30% of them met criteria for autism spectrum disorders. Intellectual impairment, male sex were independently associated with autism spectrum disorders, and younger age of seizures at onset did not contribute independently. But these were, again, not the really severe seizure disorders, because this was a community-based, so some of these children had only had 1 or 2 seizures. And then in another clinical sample from Japan, 15% of 519 patients with epilepsy had autism spectrum disorders. And then this was a study done at NYU that, even though it was supposedly a study that looked at epilepsy and autism, when you really look at the study, these were children that had been referred to a tertiary epilepsy center. And what was interesting from this study is that 33% of these patients had ASD, had at least one seizure, had treatment-resistant epilepsy. So these were kids who were really, were potentially surgical candidates, of which several of them went to surgery for their epilepsies. Again, suggesting that this population of children with autism, epilepsy, and intellectual disability is the most severe group. And then from this Norwegian study, what we again see is this clinical overlap between autism, epilepsy, and intellectual disabilities to a certain extent, with 11.2% of children with autism had epilepsy, and 6.1% of children with epilepsy had a coexisting diagnosis of autism spectrum disorder. So clearly, these, on a clinical level, these disorders are really clearly related. So why are they related? What is it that epilepsy causes autism, or somehow autism leads to epilepsy more commonly than we would expect? And so the models, one model is that there is some type of insult, let's say a genetic mutation, and then that causes the development of seizures. And from there, you would have lead to aberrant brain development, which would then lead to diagnosis of autism. That is kind of presuming that the seizures themselves, led to an abnormal development, which then led to autism. And that's possible from some of the data from the first seizures in the first year of life. It's a possible hypothesis, although the data for that is still, as we'll discuss, not very clear. The other possibility, of course, is that there's a genetic mutation that is shared by both autism spectrum disorders and epilepsy, and that the mechanisms, of excitation and inhibition imbalance, as well as maybe even migrational deficits, leads to both a diagnosis of autism plus the seizure diagnosis or the epilepsy, and so that they have common shared mechanisms. When we look at autism and we look at epilepsy, one of the things that is very, very clear is the impact of genes on this. And so this is from Huda Sogsby's work, in which she points out, that single gene disorders make up 5 to 7%, and copy number variants about 7 to 20%, and that we have unknown causes of 70%, which is this, we could call it this idiopathic group here that in 1990, was being identified in children with epilepsy. But the reality is that we all know that this is a group in which there are going to be genetic findings that are going to help us understand, the molecular mechanisms behind the autism and the epilepsy. And there likely will be hundreds of autism genes and proteins. And so the whole point, as we identify all of this, is that what are the functional relationships and interactions between these proteins in autism and in epilepsy? How do they affect different signaling pathways, and what kind of functional pathway information can we get? And then are there common targets that are amenable to therapy? So that's the importance of beginning to look at this model more closely. And again, when we look at some of the large genetic studies that have been done in psychiatric disorders, the whole idea, again, is very simple. We have some risk factors in the prenatal environment, and then we have some risk factors in the postnatal environment that might lead to autism or epilepsy or other psychiatric disorders with epigenetic changes that may affect the brain plasticity and leads you to disease vulnerability. And when these were the groups that they studied, and they found very common genes, specifically in calcium channeling, signaling, but also were present in intellectual disability and in epilepsy, which wasn't looked at in this study specifically, but have been described by other studies. The other thing that we know when we look at really single gene disorders in autism, epilepsy, and intellectual disability is there are a group of disorders. We heard about tuberous sclerosis as an example yesterday, and the relationship it has with autism and epilepsy and intellectual disability. But this is a whole host of different gene disorders that we know can be associated with both autism and epilepsy and intellectual disability. So, clearly, again, from a genetic perspective, there's shared mechanisms there that are important. What was really, I thought, a very, very important paper was this paper by Leska in the French group, in which they really looked at Landau-Kleffner syndrome, which I've already described in this type of epileptic encephalopathy, which, frankly, we really didn't understand at all what was the cause. And again, the hypothesis had been that the abnormal electrical activity really led to the behaviors associated with this disorder, and as such the autism. But in fact, what they found is that they found several genes there, many of which were already reported in autism spectrum disorder, or involved in speech and language impairment. So again, suggesting that the common mechanism is not necessarily that the seizures or the abnormal electrical activity leads to the autism spectrum disorder, but that in fact there are common genetic risk factors that lead to both autism and epilepsy. Very important when we start thinking about therapeutically what we're going to do with this group of individuals. And so this whole thing is leading us, as a clinician, now, I've been always involved in very careful phenotyping and deconstructing autism, as we heard earlier on, all the different symptoms and all that. At the same time, I think that there's going to need to be a genotype first approach where we begin to define certain genes that we know might be associated with autism and epilepsy, and then look at the phenotype of those kids to really begin to see, how these things are related very closely. And so, of course, we're going to have, this is very complicated in that we're going to have some in which one gene leads to one clinical phenotype, and then we're going to have some disorders in which multiple genes are going to lead to one phenotype, and then we're going to have disorders in which one gene is going to have multiple phenotypes, and then we're going to have to dissect that group even closer. But I think it's an important model, and I think that autism and epilepsy together maybe help us subdefine groups of children in a more specific way. So in addition to that, how does this help us understand the pathophysiology? Well, clearly, I shared to you that there is this common mechanisms in terms of potential genes that make you at risk for both epilepsies and autism. But really what we really are looking at is that this is a process. You don't just develop epilepsy or seizures just because you have this gene. Something else is going on, and they're probably altered neuronal networks. There might be structural and molecular connectivity problems. We have identified specific abnormalities at the level of the interneuron in epilepsy as well as in autism. And of course, there's altered neuronal excitation and inhibition. And the process in epilepsy is very well defined and very well studied from a basic science perspective. That is, you develop epilepsy as a process. It's called epileptogenesis. And I think that process, understanding that process is the key what everybody's doing. And we talked about rapamycin yesterday. And rapamycin is, in fact, the first medication that really is treating the process of epilepsy, potentially treating the process of epilepsy, as opposed to just treating the seizures. So you treat the seizures, you're not treating the underlying mechanisms. Sounds familiar? When we treat an autism, a lot of times we treat the symptoms, but we're not treating the underlying mechanisms, behind it. But there must be a process, just like there is of epilepsy development, of how we develop social cognitive function that is appropriate. And so we could term that sociogenesis. How do we develop social skills? And so what process is that? And we know that we can identify autism now before it's even autism. So how is that process, figure into even cognitive problems? And then potentially, how does that then lead to epilepsy? And how is this shared? What are the common mechanisms? So one level that was very strikingly, was a striking surprise is that in fact, there are common mechanisms in terms of neuropathology. So when you look at neuropathology, this was a study done in 27 individuals, 13 with autism and 14 controls. 6 of the 13 had epilepsy at some point in their life, 46%, and 5 of 6 of onset of seizure was 14 months to 5 years, and 1 had a seizure at age 23, which was the cause of death. But when you looked at the pathology, there was evidence of cellular disorganization reflecting abnormalities in neurogenesis and neuronal migration, and so 92% of autism brains have subcortical, periventricular, hippocampal, cerebellar heterotopias, dysplasias that in fact, were the same findings that we find in epilepsy. These were not being seen on MRIs, of these kids. These were only seen when we went and did the pathology. And so very, very important in terms of understanding that there may be the same substrate at an anatomical basis that may lead to the disruption in circuits. And then this paper just came out in New England Journal of Medicine, included, people like Eric Kirchains and others from the University of San Francisco, looking at, again, autopsy studies in children with autism. And what they found was focal patches of widespread abnormal laminar cytoarchitecture and cortical disorganization of neurons, but not glia, in prefrontal and temporal cortical tissue. And 10 of the 11 children with autism, and from 1 of the 11 controls, these things were found. And what was interesting is there were very similar pathological features across these cases, which was really quite unexpected. Again, the type of abnormalities that you would see in epilepsy as well are being found in autism, really showing the biological aspect of this disorder and the importance, of bringing that out to the public as well. There was disorganized patches in different locations. They're hypothesizing, and I would agree with this, that this makes sense from a neurology perspective, would disrupt very different prefrontal and temporal cortex. So when we think about autism and when we think about epilepsy, we're thinking about neural networks. And so if you disrupt one aspect of the neural network, you might get a child, with autism spectrum disorder that has more repetitive behaviors or less repetitive behaviors, or more social dysfunction or less social dysfunction. And in epilepsy, we might get different types of seizures depending on where it gets disrupted. So thinking in terms of these neural networks is important. And so that's why a very discrete lesion in one part of that neural network may create havoc in terms of brain development. And so I think this is very important in our understanding. And also what I thought was very interesting that they hypothesized, which again is a very interesting hypothesis, is that the apparent patch in one control substance raises the possibility of a subclinical patch phenotype. That is, maybe there are some kids who don't meet the full criteria of autism but have some of this disorganization, and that there may be some anatomical substrate behind that. And I think this is very much related to how we understand epilepsy and puts autism and epilepsy kind of sharing some very important anatomical substrates and an understanding of how it affects the neural networks of both of these disorders. Now, of course, since 2002, we've understood, that there is this increased risk, that there are these mini columns, which are the smallest unit of information processing, and they're abnormal in autism spectrum disorders. And then there's also a whole group of interneuropathies that have been described, in terms of epilepsy, including those from mutations of the ARX. And then this recent paper, again, using an ARX model of X-linked infantile spasms, they were treated in an animal model treated with estradiol stimulation, prevented epilepsy. And so the question is, as we're understanding that from epilepsy, and we understand that the same neuroanatomical models are can be seen in autism, we begin to see how this is going to be very important in terms of therapeutic options for both disorders. So as we move on to circuitry and how we understand how the circuitry works, there's probably it's the hypotheses, and this has been Amy Brooks-Coyle's thoughts now for several years, is that there's abnormal excitability in the developmental brain that leads to epilepsy or epileptogenesis. And I'm suggesting, this is kind of my little in there, that the same thing happens in terms of social cognitive function, and so leads to cognitive and behavioral problems. And then the epilepsy itself may add some further problems to that. And so what is the evidence for that? That there are these disruptive circuits the same way that we see them in epilepsy in terms of excitation and inhibition. Well, the work of Rubinstein and Messernick from 2003, and then this work from 2011 clearly suggests that in autism spectrum disorders, we also see this excitation and inhibition in balance in this function. And in fact, there is a whole group of genes that have been identified in autism spectrum disorders, and also many of which exist in the epilepsies, in which in fact they are genes implicated in excitatory inhibitory balance related relationships. So this, again, gives us evidence that we're on the right track here in understanding that. And then I just want to take a last few minutes to talk about what this means in terms of treatment implications, if you will. Because if we understand that, we share mechanisms between the two disorders, I think there's several important questions and implications that we need to begin to understand in terms of this process. We know that in children with autism, just like in children with epilepsy, let's say you're at risk for epilepsy because you have some genes and maybe something else happens. In autism, it seems like maybe the same thing is happening. You could have these abnormalities, whether they're anatomical or genetic, that put you at risk for developing autism, and then something else happens. Because when we look at some of these early infant studies in terms of recognition of autism, what we're seeing is that at least in the first 6 months, a lot of these kids really do develop normally. And it's after 6 months or so, maybe up to 12 months, that then we begin to see the symptoms, clearly that we can then say, that's going to be led to autism. So one of the things that I think is true is that we have maybe a developmental trajectory in autism spectrum disorders that is kind of like this social genesis thing, which gives us a window of opportunity that we might be able to intervene. And second of all, I think that this relationship between autism and epilepsy allows us to begin to think about these epigenetic effects in a very interesting way in modeling the effect of seizures and epileptiform activity as an added effect on how it shapes social cognitive development. And there's some studies now in epilepsy in adults doing fMRIs and using paradigms such as theory of mind, suggesting that over the years, you could see some changes in theory of mind in individuals with seizures of the temporal lobe. Again, very preliminary data, but very interesting data. And then the other thing that's very important is this early identification and the use of early intensive behavioral intervention. We now know that early intensive behavioral intervention clearly shows that it helps children with autism spectrum disorders. It increases language function, increases IQ, and increases, some of the adaptive behaviors. So the question is, if that's true, if really we know it's true because we've seen it and the data is there, here's all of that, then can we use these in at-risk populations, such as populations in which seizures start in the first year of life? And then what kind of a difference can we make in those kids? And so from that perspective, it might be an interesting model to be thinking about. From another perspective, early identification is now becoming important, which this article by Mustafa Sahin on tuberous sclerosis and autism, No Longer a Dream, I thought was very eye-opening in terms of now these possibilities and all of these different studies that are being run now, not only to treat tuberous sclerosis, but for treating Rett syndrome, Fragile X, and Down syndrome. And if you see what the targets are of this, what we're targeting are things such as cognition, memory, and language. And keep this in mind here, memantine, which has been used in children with autism spectrum disorders, it's an NMDA receptor antagonist, has been used in Down syndrome. The studies weren't that great, but the measurements of what we're, meaning the study outcomes, the effect of memantine was hard to measure. But nevertheless, what they were trying to do in these studies are quite laudable in terms of the target that they were trying to improve. And the fact that we're even attempting this at this point is really very important. And then when we look at it again, looking at both the epilepsy world and the autism or intellectual disability world, I think that there's a couple of things that I want to point out. One is this is an AMPA receptor antagonist, NBQX, that's being used by Francis Jensen's group using an animal model of neonatal seizures. And it not only stopped the seizures, but they looked, again, in those animal models that we saw yesterday being described, it decreased also autistic-like social behaviors. And this article by Chris Walsh and Picker is, I think, a very, very important article in terms of new innovations for intellectual disability, which has incredible implications from a pharmacotherapeutic perspective for autism and epilepsy. But now there are multiple targets. We talked about the mTOR target. Here's the AMPAR target that we talked about here. And then in Fragile X, we have these targets. And so these are the maps that are now being created, and these are now allowing us to really think about medications that, frankly, we never would have thought about in terms of potentially having an effect. And then you think about that for 1 second. If you can tie in some medications, as we heard a little bit when we're talking about oxytocin and the social brain, together with this early intensive behavioral intervention, we may make some significant differences, in the near future in regards to what we can do for children with autism, epilepsy, and other neurodevelopmental disorders. So they're very, very exciting time. The question, that comes up is we've been somewhat disappointed, and I think that maybe our expectations are so high now that we have all of these things, and so the question is, are we there yet in terms of targeted treatments, for epilepsy, intellectual disability, and autism spectrum disorders? And I just wanted to mention this that just came out actually in the Annals of Clinical Translation Neurology. And this was a GRIN2A mutation, which has been described in autism spectrum disorders, was for the first time described in an early onset epileptic encephalopathy. And then they basically screened with different biological compounds after they did that. And they found that memantine in this particular child, helped decrease the seizures. It's not a medicine that we ever had thought for seizures. And I think this is kind of personalized. This came out of the NIH group. This kind of personalized genomic type of medicine is going to have very, very significant implications for the types of patients that I think we are taking care of. So kind of in summary, I think that, we've discussed that these are a group of things, such as the epilepsies is not one thing. We talked about the shared mechanisms between epilepsy and autism spectrum disorders, and in fact, intellectual disability plus ASD syndrome. We talked about the fact that this is bidirectional. We talked about risk factors. We talked about the risk process, and we talked about, again, this epileptogenesis, this process here in terms of developing epilepsy and sociogenesis, and the importance of understanding these mechanisms, and not just understanding seizures or the symptoms of autism, but what is underlying it in terms of intervention, because these are the ways we're going to develop interventions from a behavioral and molecular perspective and pharmacotherapeutic perspective that are much more targeted interventions. But I do want to leave you with a few kind of questions and comments, or thoughts, if you will, regarding it. So does epilepsy cause autism spectrum disorder? Well, there's no evidence for that at the present time. It doesn't seem that it causes it. But maybe a more important question is, what is the contribution or added effect of epilepsy or abnormal electrical activity on the development of autism? I think that's still a very interesting question that we need to think about. And why do children with the same type of severe epilepsies have such different developmental outcomes despite treating the seizures? And what I mean by that is, I said to you that 30% of children with infantile spasms go on to develop autism. That means 70% don't. So what's different about the 70% that don't? We're all kind of focused in, on these are the causes. What's protective in some of these group of children? And then more specifically, if we can effectively treat before the diagnosis of autism. So when I see a child in my office, at age, 14 months, and they're not pointing, and they're not, using eye contact, and they're having a few little repetitive behaviors, I don't know that I have enough data to say, okay, this child for sure has autism. I do know that child is clearly at risk for the development of autism. And I don't believe that it's, at least in my view, ethical for me not to suggest to them that intervening at that point is very important, especially intervening, with behavioral interventions, which, again, what is the consequences of that? I do think, though, that I think this is very, very important in terms of stopping the development of autism and epilepsy. Maybe this would be a really good group to look at if we can really begin to think about it. If you have a group of kids with very early onset seizures, what would happen if we did intervention in them? What happens right now, I must tell you, is that even in comprehensive epilepsy centers like the one we have at Miami Children's Hospital, which is fairly well recognized worldwide in terms of the epilepsy care, really, I don't see the children in my clinic, if you will, from an autism spectrum disorder till many years afterwards, because everybody's so focused on treating the seizures that nobody has bothered to treat all the other developmental problems. And I think we need to raise the consciousness and raise awareness that, autism spectrum disorders does occur in populations such as epilepsy a little bit higher. And I think this is very, very important, with implications that we might be able to do something more to help these children. And then, does ASD cause epilepsy? Well, I think that there are clearly evidence now that there are shared mechanisms that lead to both disorders. And I think one of the important questions is, what is the contribution or added effect of autism spectrum disorder or of poor social cognitive development in children with epilepsy? So there's a burden to having this as well to epilepsy, and it may be that makes the epilepsy worse. And in fact, there are some studies in animal studies in rats with epilepsy, in which you put them in an enriched environment without giving them any medications, and their seizures actually do decrease. So it's an important piece of the puzzle here that I think needs to be looked at. And can we identify those children with ASD who are going to develop epilepsy? Clearly, this would be a very, very important group. So it's not only saying that, are we going to find some genetic markers or other biomarkers that tell us that you're going to develop autism, because autism is so heterogeneous that you might do very well. But if we can develop biomarkers which say, you could develop, this is a child at risk that is going to get autism, epilepsy, and they're not going to do that well. These are poor outcome measures, then we might be able to use that group of kids, to see those kids needing much more intensive interventions, not only behaviorally, but we might be a little bit bolder in testing some of the medications appropriately on that group. And lastly, if we can increase IQ and attenuate ASD symptoms through early intervention, can we modify the development of epilepsy in ASD? And I think that's another interesting question, that is there. So I leave you with this. Thank you so much for listening, and I hope that this panorama of the ocean view, kind of tells us we still have a lot of uncharted territory. But I think that this type of information is, for your generation, for the younger generation here of researchers, I think that it's very, very encouraging, and we should be very optimistic about what we can do to help children with autism spectrum disorders and epilepsy. Thank you very much.